really, this is just a sort of an illustrative talk on some of the work that's been done, and I'm the guy giving it. This is a group effort of a lot of people, many of whom are in the room, some of whom are, out with the room. So look at me as the guy just kind of giving this illustrative talk on the issues of open wound management and open fracture management. And a lot of this stuff was done at MAC and places in the vicinity. I'm not going to dwell on this. This is Perret, and he was, a few hundred years ago, only to illustrate the point that, in fact, open fractures, they've been talked about for a long period of time. This is in the 1500s, and it's actually really interesting because he's actually telling someone how to, treat him. He fell off his horse. He says, okay, pull on my leg. Okay, cut the skin out. And he's sort of kind of watching him do this and wash it out. And the reason that I bring it up is because in 2009, we still don't know the best way to wash out an open wound. And they are worldwide issues. There's MVAs everywhere. There's wars going on. There are open fractures in and around themselves. And the issues is they have problems. They have infections. They have non-unions. They have wound healing problems. So the issue is it's a problem. And the goals of the open fracture wound management have not changed since the times of Perret or Hippocrates for that matter. And really we're looking at preventing infection, wound debridement and copious irrigation being the mainstays of treatment, initial treatment of open fracture management. And just as another point, just like Mike said last night, any clinical pictures here have patient consents and all that sort of stuff. Debridement is very important. It doesn't take a rocket scientist to know that getting the grass out of the bone is probably better than leaving it in. And the way to do this, the things that are different from the 1500s and the ancients is that, we have guns, we have high pressure things that can deliver fluid at vast rates to try and clean out these wounds. So the issues of open fractures and bones coming out of the skin are we need to clean it, we need to get rid of any dead bone, necrotic tissue, and try and get the bone back together to heal, to decrease our issues of infection and wound healing problem. So there was a lot of soft tissue literature looking at these devices, these high-pressure pulse devices and low-pressure pulse devices, and they were seen to be pretty effective at removing bacteria from soft tissues. You would blast the stuff at the soft tissues, get rid of the bacteria, and decrease your infection rates. But the big question initially was, and the group decided to look at, well, what's the effect on bone? Is high pressure great at debriding soft tissue? Does it have the same effect on bone? And so when you look at some of the basic science behind that, there's the question, does high pressure affect bony architecture differently than low pressure? Maybe not the best worded, but if we look at bony architecture, starting on the left and moving towards the right, experimentally, the group decided to look at that. You can see that there's actually potentially increasing severity with high-pressure guns firing soft tissue, firing fluid at bones, and it actually tends to destroy the bone. This is argued back and forth. Again, experimentally, if you look at where does the bacteria go when you start shooting high-pressure stuff into bones, you can see that in actual fact, this is the fracture site. This is the distance into the canal. The largest colony-forming units were actually a couple of centimeters past the fracture site. So one argument is, well, you know what, high pressure may work for soft tissue, but it looks like it actually hurts bony architecture. And you know what, it may actually drive bacteria into the bone. Is this something that's good? Is this something that's clinically good? Don't know. What does it do to the adipocytes and the mesenchymal stem cells? Well, if you look at high pressure, as Mo and Emil have done, at the osteoblastic lineage, you can see with increasing pressure, there's an increasing transformation from osteoblast lineage to fat cell lineage. And in fact, they were doing basic science work looking at adipocyte cell formation after low pressure, which is low, and high pressure. So the question is, well, it looks like high pressure may affect bony architecture. High pressure may drive bacteria into the bone. High pressure may actually change the stem cells from changing to osteoblast into adipocytes. Experimentally, high pressure may not be looking as good as arguably you would see in the soft tissue setting in clinical. So the question then is, well, what about low pressure? Is that advantageous? Is that better? So if another hypothesis was that using low pressure with different irrigating solutions. So the argument is maybe low pressure is a bit better based on some of this experimental work. Well, what about in actual fact the solution that the low pressure uses? So we know that you can use saline, you can use soap, you can use bacitracin, you can add antibiotics. We all use chlorhexidine, we use povidone to prep limbs. We know that those kill bacteria. Maybe that's a good thing. So if you look at the bacterial colony forming units looking at all of these things, saline, alcohol, povidone, soap, antimicrobial washes, if you add low pressure and these groups here, you can see that in actual fact soap is actually quite good at taking bacteria away from tissues. So we're going from using low pressure and then adding different bacteria or different fluids. So it looks like soap may actually be pretty good. You can see that some of the other ones are good at getting rid of bacteria alone, but based on this work, povidone, alcohol, and those things also damage tissue. So those things, the bacterial decreasing properties of some of those antiseptics, povidones, and all that sort of stuff come at the expense of potentially damaging tissue. Whereas saline and using soap gives the same sort of effect without the damage to the tissue. So we're starting to see, well, maybe low pressure is good. Maybe using soap isn't too bad at getting rid of some of this stuff. And this is what we see from an experimental point of view. Again, this is what I was talking about. If you look at bone nodule formation, so the ability of bone to form after using saline, alcohol, iodine, soap, antibacterials, and chlorhexidine, you can see that the bone is actually forming better with the saline and the soap. So good at reducing bacteria, not so bad at damaging bone. Maybe this is what we should be moving towards, at least experimentally. So the question then is, well, in these in vitro experiments, that's one thing, but what about in the in vivo setting? Let's move to something that's a little bit more, in vivo. And so what the group did was develop an animal model, a rat animal model of femur fractures. So here's where it was done, all the appropriate ethical things in place, and this was the fracture delivering device here, and the fixation technique using a K-wire into the femur. And what they really wanted to look at was high pressure versus low pressure, and does this affect the actual fracture? Does this affect the callus? Does this affect the biomechanical structure of the bone? And it looks like, in fact, that high pressure irrigation did result in a lower bending force. That means the bone was a little bit weaker, the callus wasn't quite as good. So now you have issues of high pressure may be affecting bony architecture, high pressure may be affecting cellular things, high pressure may actually be affecting the clinical callus that you see with these things. Now where do we go? So this work was started early and late in the 90s, and the thing that you want to ask is, well, okay, so what do people do? What do surgeons use? They've got the guns, they've got the high, they've got the low. Are they doing what may be in this experimental literature? And so we asked them here, what do you do? And it looks like 61% of them used low or low pressure, and fully 40% of people used high pressure. So there's still a big split in terms of actually what's going on clinically versus what people are potentially seeing experimentally. Now, just as one other thing, to address some of the issues of irrigating solutions, after this, a large trial came out that looked at antibiotic solution, bacitracin, and saline in open fracture, saline and bacitracin versus soap in the open fracture model. And they found no significant difference between this is Anglin's big study of 458 open fractures. But there was a slight trend that saline may be better than, soap may be slightly better than saline and bacitracin from this. It wasn't really statistically significant, but there was a trend to suggest it may be a little bit better with respect to infection and wound healing problems. And so we asked surgeons, again, well, we've got an RCT, we've got some basic science work that shows us, well, you know what, soap and saline may be better at removing bacteria and without the same effects on bone. Low pressure looks like it may be better with respect to bony architecture and shoving bacteria into bone. So we asked them again, what are you using? So going back and asking surgeons, what are they using? So again, this is, the first one was published in 2002. This one's just published in 2008. You can see that it's pretty much the same split. People are still using low pressure. People are still using high pressure. When we ask people what solution they're using, 70% of people are using saline, and 17% are using saline and bacitracin, and 1% are using soap, which arguably from some of this literature may be slightly better. So now we've got experimental work, we've got some in vivo work, we've got knowledge of what people are doing in practice. Where do we go from here? And the question would be, if you want to design a trial, what are you going to do? What are you going to trial? This was published just a couple of years ago again, sort of an editorial / review that said normal saline should be used, many antiseptics and antibiotics have been employed, no consensus has been reached, new systems for debris are currently being investigated, an ideal method has yet to be determined. No major difference from 1500, no major difference from the ancients, arguably. So what we asked the people in the survey as well was, well, you know what? Do you agree or disagree that there's a need for further trials? 85% said, yeah, I think we need further trials. So surgeons, people that we asked, are actually calling for trials, arguably, with a little bit of prompting from us. 78% agreed or strongly agreed that there's a need evaluating pressures, a need for evaluating solutions, and 90% said they would change their practice if a large RCT showed a clear benefit of one solution over another or one pressure over another. So now we have opinion of people doing the work. Yeah, I'll change if I see something that's good. Now that's an argument you can have in your small groups. Do we change practice based on an RCT, et cetera, but that's a separate argument. But the other thing that we asked them that I thought was very interesting was, okay, you're going to change your practice based on an RCT. What size of effect? How much reduction in the risk of infection, wound healing problem, or non-union are you going to accept before you change your practice? This is the concept of clinical significance. What sort of effect do you want to see? And they told us that the majority picked 25% or less. They said, I'll change my practice if you can tell me that there's a 25% relative risk reduction in infection. Some said 15%, some said 10%. But the cutoff was around, for the majority of people, 25%. So then we asked them, would they participate in a randomized trial? 63% said they would. And then we talked about the need for randomized trials. So now we said, okay, you'd like to see a trial. Some of you would agree to participate in it. What's your level of clinical significance that you want to see that's going to make you change your practice? So now we're starting to think, okay, what are we going to build in? What are the numbers, et cetera, et cetera, et cetera. So this led to this collaboration of flow investigators to look at the fluid lavage of open fracture wounds. So the first thing, as we've been hearing, we've got some funding, we had some funding for a pilot RCT based on treatment effect sizes on the one large open fracture randomized trial that was done. There was event rates of about 13% and 18%. We were calculating what we would need to do to tease out any differences, and you're looking at a couple of thousand patients. So people don't want to really start to fund the study for a couple of thousand patients until people see that you can work as a group, that you can enroll patients, that you can follow patients up, that there's a system in place that allows you to do this. And so that brought together the group of Flow to bring together a group and assess the feasibility of doing a large randomized controlled trial. We needed funding, so we did get funding from both the PSI Foundation and the OTA, and that was about $150,000, I think, something like that, about $150,000. The interventions were normal saline and soap Now, you're going to say, well, hold on here. 17% of surgeons are using bacitracin as well. Why didn't you put bacitracin in there? We got saline, we got bacitracin, and you got soap. So we had arguments and debates because there was a steering committee looking at this, and we argued that, well, Anglin, a large RCT, showed that, in fact, soap may have been slightly better than saline and baci. Saline is actually the standard of care based on our survey of 980 surgeons, arguably the standard of care. So we chose to do that. There's issues of bacitracin allergy, its cost, etc., but we chose to look at that.